Hello and good evening, afternoon, morning to everyone, wherever you are in the world. Thank you very much for joining us today for this COVID-19 Innovative Epidemiology Solutions. Now, I have one of the most diverse international panels that I've ever had. And I really appreciate everybody who has been awake early in the morning or awake late in the night because we're crossing so many time zones. And so, what I'll do is quickly introduce everyone before we start going into the discussion as to what we have. Here we have everybody with us. Do you mind unmuting your mics? Wonderful. We've got everybody here with us. And what I'll ask everybody to do is to just do a quick 20 to 30-second introduction of yourself. Since you're closest to me, Nut, do you mind going first?
I'm a theoretical epidemiologist and started my work in Tübingen in Germany, predicting at that time that HIV would not spread among Caucasian heterosexuals, and it didn't. And then I worked in Egypt and in Lebanon, and for 20 years at the Rockefeller University in New York as head of biostatistics, epidemiology, and research design. And now I'm running a company that works on drugs and on nutritional supplements, helping to fight complex and common diseases.
Excellent. Wonderful. And Catherine, we've got you here as our lay expert.
Hello, Philip. It's very, very lovely to be here. My name is Catherine Gray. I'm the e-learning consultant, and I have been working with Philip on the course to create this absolutely amazing, groundbreaking course and bring this to the world so that people can inform themselves with COVID-19.
Wonderful. And it's important to say, Catherine, you are here to keep us on track with regards to the science. Excellent.
Yes.
Amitav?
Good evening. I am Dr. Amitabh Banerjee. For 27 years, I worked in the Indian Armed Forces, mostly as a field epidemiologist. I headed the mobile epidemic team also. For the past 17 years, I am leading a more quiet life as an academician. For the past 2 years, I have been involved in the task force for COVID control in the district as an advisor and as a field service.
Excellent.
Thank you.
Excellent. And Caroline?
Thank you, Philip. I'm a family physician in Canada, Vancouver, British Columbia on the West Coast of 35 years in private practice. I also have experience in organized medicine in a number of leadership positions, including our medical association. I recently obtained academic training in New York, studying a Master of Public Administration to acquire knowledge on evidence-based policy and management. I'm known as a physician advocate, and my interest is to promote patient-centered care and improvement of our health system based on quality.
Excellent. And Jennifer?
Good morning, everyone. My name is Dr. Jennifer Smith. I have a PhD in microbiology and molecular cell sciences with a subject matter expertise in respiratory viruses. I've done research studies on vaccine development and testing in animal models for preclinical approval for FDA trials. The last approximately 5 years, I've worked as an epidemiologist at the Hawaii State Department of Health. So I had boots on the ground experience with case investigation and contact tracing, starting from day one from the pandemic. I've investigated well over 700 cases of COVID.
Excellent. Thank you very much. And what about Sean?
Hey, Philip. Good evening, good day, good morning. Assalamu alaikum to everyone around the world. Philip, by the way, happy belated 50th birthday.
Oh, thanks for reminding me.
You're looking good for 50, my friend. Ladies and gentlemen, my name is Sean Kaufman. I'm CEO and founding partner of Safer Behaviors. I have 27 years of public health experience. I've worked for the state of California. I worked at the Centers for Disease Control and Prevention. I worked at Emory University. I've also worked with WHO, and I've done a lot of international work. My background is in behavioral psychology and infectious disease. How do people behave with infectious diseases, not only during outbreaks and normal lives, but also during the pandemic? So, Philip, again, it's great joining you. Thank you for having me.
Excellent. Thank you. And Shabir?
Hi, everyone. My name is Dr. Shabir. I'm a neurologist. I am the managing director of Universal Hospitals Abu Dhabi, and I've been quite active in the COVID scenario in India as well as in the UAE. So, I mean, here I am. Thank you, Philip, for inviting me onto this platform, and I hope to be of some assistance for you in what's happening in this part of the world. Thank you.
Excellent. Thank you very much. So that's our panel, and it gives me the opportunity before we start to discuss some of the challenges across the world. I'm going to be sharing with you some work that we have been doing with regards to a course on COVID-19 that we're starting to develop in conjunction with some e-learning expertise. I'll give you this very short video to give you an idea as to what it's about.
COVID-19 Foundation 360 is a 6-module comprehensive course, representing the first comprehensive review of COVID-19. This is the first course in the world, designed to explain all aspects of COVID-19. It is a unique offering, breaking down complex scientific topics, to provide a 360-degree understanding of COVID-19. The Foundation 360 was developed by Dr. Philip McMillan, a physician in the United Kingdom. From the beginning of the pandemic, he has conducted research to improve understanding of COVID-19. In April 2020, he proposed that severe COVID-19 is an autoimmune response triggered by the virus. Since then, he has co-authored and published 2 papers outlining the theory of autoimmunity and COVID-19 and providing a comprehensive explanation of the associated symptoms. Dr. McMillan has also hosted over 40 interviews with health, medical and science professionals across the world. Time to empower yourself. An improved understanding of COVID-19 helps to increase confidence and reduce anxiety about the pandemic. Knowledge is power. Boost your knowledge. Learn about which groups are vulnerable to severe COVID-19, how the virus creates unusual patterns of disease, and much more. This COVID-19 Foundation 360 course has been developed in conjunction with an expert e-learning course creator to ensure that the valuable findings of our groundbreaking research are delivered effectively. We invite you to join us on a journey of discovery. Support this work and learn more about COVID-19 as we share the findings of our innovative research.
Oh, thank you very much for that. And I'll quickly just have a chat with Catherine. Hi, Catherine. You've been helping us to develop this course, and you've taught us some very important principles with regards to breaking down content into really simple and digestible parts. Why is that so important?
With as complex topic as COVID-19, the main problem has been that the public haven't been able to understand any information, that there's been very little given. And to take something like this, you need to, in order to transfer the learning from the course to the student effectively, you need to use a range of educational principles. And you need to kind of get inside the psyche of the learner's head. And by micro-chunking, what you're doing is you're actually teaching them the terminology, but in easy to digest portions. So therefore, the learner will retain more information. And also, from a motivational point of view, it gives them a huge boost to sort of realize that they've understood something which is, before they started the course would have been too complex for them to even imagine. Very, very important project, and I feel very honored to have been involved with it.
Wonderful. Thank you very, very much, Catherine. So I can only praise Catherine for her technology and the wonderful skills that she's given in terms of being able to create that. So for anybody who is interested, Macmillan Research will put a link afterwards to what is happening. So thank you. And now what we're going to do is move straight along and bring in all of our people. I think that we're going to have Amitav starting first to have a broad epidemiological perspective with regards to what's happening in the world. Do you want me to share your slide?
Yeah, show me that three continents. I have selected few countries from the beginning. What we have been noting, the pandemic is not having an equal impact across the globe. The northern hemisphere, the impact is more particularly related to mortality, and the southern hemisphere, the African and Asian continents, the mortality is 1/10 to 1/6 or 1/10 of the mortality of the northern hemisphere. Can I have the next slide, Philip? The next one, next, which is showing the this one. So I have put the red in the European and American countries, and the Asian countries in green, and the blue is the African continent countries. So if you just see the median age, the first column, higher median age 40 plus in the Europe and all, we are having, and the BMI, the second column is the BMI above 25. So higher BMI, and the deaths per million is in 4 digits, almost in 4 digits in all the countries of the northern hemisphere. Whereas it is 3 digits in most of the Asian countries, and African countries 2 digits. And if you see African countries, South Africa having a higher BMI, higher rates mortality. So there is a higher age, and Japan and Brazil are very interesting. Japan is having the highest age, higher than even the northern hemisphere, but it has a low obesity, 27%, and its mortality is even lowest in 3 digits only per million. And the last three columns are the last two columns are the immunization status, that is partially immunization and completely immunized. And the third last column is the deaths in the per million in the past 7 days. So if you see, the immunization coverage is not having much. Still the Asian countries are having 1/10 of the, with lower immunization. The Asian and African countries are having still lower deaths than the higher immunized northern hemisphere. So what it comes out, the age and the obesity, particularly obesity, is having a bigger impact on the impact of COVID than even vaccination. See, Brazil is an interesting example. With a younger age, it has got a very high obesity, 20, and it is still struggling with the higher mortality. So this is the first slide. The second slide is very, we thought with the, this is important to see the age-wise. Age-wise, if you see the younger ages, the survival is almost 99.9970 to 19 years, then 99.98 up to college going. So schools and colleges could have been kept open, and still they are closed in many countries. And similarly, the age, the risk is higher, 60 years above, 99.41 and all. So with this low mortality, any outcome, whether it is a antiviral or a vaccine or any protective, it will be difficult to evaluate the attributable risk. So this is one thing which we will be very difficult to identify any intervention. Then I would just one more slide. Some countries, they rolled out the vaccination. That initially, before the vaccination, it was much lower, say the Sri Lanka. And after vaccination, partial and immunized, the rates increased. Similarly, the death rates, the next slide shows the death rate. So this feature has been noted. You see, it's almost baseline death before vaccination, but after vaccination, when we expect the mortality should come down, whether it is due to some Delta virus, which has been, some people have expressed concern that it can lead to mutation, it requires to be explored. And now there is a recent study from 68 countries and more than 2,000 counties in USA which are showing the same trend. So here we have to pause and think how much impact we have in vaccine, because almost all the countries are going for mass vaccination. So we have to see whether we are going to get the bang for the buck. Thank you.
Absolutely. Well, wonderful. That is quite remarkable. So what I'll do is I'm going to bring Nut in to share his view on this. I'm just going to share your screen in a second, Nut.
One thing that you will all see is that we are actually very close and are drawing almost the same conclusions, even though we're talking about the disease in different parts of the world. And I'm talking mostly about the United States. Can I see the next slide? This one. No, that's not the next. Oh, no, it is, sorry. And what we see is, as we have heard before, it's still predominantly a disease of the old and vulnerable. at the top in blue, and not of the young people in light green at the bottom. So that has not changed fundamentally from what we have seen initially in the north of Italy last year. Go on.
Mm-hmm.
What we now see is that we have waves, and the current wave, interestingly, looks very similar to the wave that we had early in 2020. And early in 2020, nobody was vaccinated. And now we have 95% of the over 65 people who are vaccinated at least once, and some of them also have immunity from infection. And that is enough to prevent even a disease like measles from spreading. So the disease is not spreading, or would not be spreading in nursing homes or other places where the elderly congregate, because if you have more than 90 or even more than 95% of people immune, a disease cannot spread.
Mm-hmm.
And here we see that we have a very similar pattern in industrialized countries in the US and Europe, and Oceania. What we see is, in the sense, there are three big waves that were coming, and they are less than a year apart, meaning it's not a seasonal disease. And we don't see much of a difference between the level of vaccination and the level of the disease. Like Oceania has the lowest level of disease and also the lowest level of vaccination. And
Mm-hmm.
between the other countries, we also cannot see a clear difference that the vaccination would make.
I'm going to pause with regards to those two things. Those are absolutely fascinating statistics that have both come, as you said, from different sides of the world. I just wanted to pull in Jennifer here from your virology experience. Does this make any sense from a coronavirus point of view?
So I'm not really certain what the differences are. It's interesting to see, as they pointed out, that in the US we have higher rates of obesity, which is known to be a high risk factor for severe disease. So, when this first started last year, we started to see more mortality in places like Italy and Europe. And I thought to myself that there may be some genetic differences as far as susceptibility to the disease, but that's yet to be teased out.
Mm-hmm. Fine. And when we think about the experience in, say, for instance, the UAE, Shabir, does any of this seem to parallel what you guys are seeing? Or are you guys, because you're very heavily vaccinated, aren't you?
Yes, that's right, Philip. So basically, what's happening? I think I would like to appreciate the rulers of the country for bringing in so much of efforts to curtail this problem. Because if you look at UAE, only 10% of the population are the natives, and the 90% are expats from different parts of the world. So there is a problem wherein people are on visas for application of jobs. They're stuck there. They cannot go back. So the government has taken a very, very rational approach. I think the findings are almost the same, but I think there have been very meticulous and there's a lot of financial implications that had happened to the government, and that's why you see less than, today's count is about 130 patients with only one death. So there has, the expo is going on. Millions of people are coming from different parts of the world, and this is what's happening in the UAE. So I prefer that Singapore also was doing this model, but I think something is really wrong in Singapore at this point of time. So I totally agree with the study, and possibly one of the biggest advantages that we have in the UAE was the strict adoption of people traveling, because even to people to travel from Dubai to Abu Dhabi, we had issues. And, every school going kid has to get tested once in 3 weeks. So, it was tough, but I think it is showing some amount of results now, because the culture is different. I mean, the reopening is slightly different. And we have the Crown Prince announcing that, we have almost won the war. So I think that's a good sign. I agree to what the people were saying.
Yeah, right, fine. And say, for instance, Caroline in Canada. Canada is taking a very aggressive position with regards to managing the pandemic, with regards to vaccinations and so on. What is the reality on the ground? Do we see a huge impact? You're muted at the moment, Caroline. I'll unmute you. Yes.
Yes, thank you. Canada is currently in the midst of our fourth wave, mostly Delta. Our pandemic response has largely followed that of the US, in that our focus is almost entirely on mass vaccination. Currently, our rates are quite high, is around 80%, and as you say, well over 90% in the older age groups. However, the government has instituted quite drastic policies, including a vaccine passport and mandate, with the intention to vaccinate as many people as possible. It's not clear what their goal is. From early in the pandemic, there was talk about reaching herd immunity, which should include natural immunity as well as preventive measures such as vaccinations. But now the focus is really more on a one-size-fits-all. The media has largely represented the dominant narrative of the government, calling this a pandemic of the unvaccinated. And this has caused quite a bit of division and fear in our society. So my concern as a physician is that an unintended consequence of this policy has been essentially one of top-down control from government of how doctors can treat our patients, and virtually ignoring really the importance of therapeutics, particularly early outpatient treatment, to the point where physicians are now told that we cannot prescribe repurposed drugs such as ivermectin and others, and individual physicians have in fact been targeted and suspended, including their license. So there's a great deal of fear and distrust currently.
I can imagine that, and we'll probably be able to discuss some of those challenges, certainly from the India perspective and so on. But I wanted to ask Sean's idea here now, in terms of from a behavioral point of view. How is it that people are responding to all of this? This seems to be quite a complex situation.
Well, Philip, I think as the pharmaceutical companies, social media, the press, and politicians are all working together quite smoothly with a common narrative, the public health professionals, the scientists, and really the healthcare workers are all squabbling. We're fighting. We're not unified, and we're divided, and we're fighting each other. And I hear what Carolyn's saying, and I agree 100%. We really need unity. I mean, imagine the day when doctors no longer have the choice to choose what to do with their patients. They don't have the creativity to practice medicine. All they're doing is delivering medicine. They're delivering a prescription, so to speak. It's very frustrating. It's frustrating to witness because usually what makes public health, science, and healthcare better is the ability to respectfully disagree with one another, to have a dialogue, to make observations from the front line and come back, discuss it, and continue to practice what it is we're doing. So to witness what we're seeing, in my opinion, is quite sad. And really, to be honest with you, I think people are wanting to get back to normal. Government is blocking that. I think we have lived around infectious diseases since the beginning of our time. I think it's something that people really want and should be put in control. They should be given the decision and the choice to actually do what it is that they want to do. So from a psychological point of view, that's, again, my background is in psychology. I can't stand it, Philip, when people say, well, vaccine mandates work. No, they don't. There are single parents out there that need jobs. There are people that have retirements on the line. There are people that don't have the strength or the ability to fight people with money and with power. And so they get shots because they're coerced and manipulated. It's not a success story to say, my goodness, look, we're getting all these people vaccinated because of the mandates. It's really, truly sad. It's coercion, it's manipulation, it's bullying, and they should be ashamed of themselves, in my opinion. The people who are running this show should be ashamed of themselves.
It raises an important point, though, and I'm sorry at the moment we don't have Dr. Shahzad Khan from Pakistan with us, because he was emphasizing the challenge that public health have is because public health still have to try and deliver health across the country. They have to pick a broad approach and they have to pick a winner in a sense. And if they think that vaccines are the way out of the pandemic, they have to do it in some kind of unified way, which they have tried to do. Whether it's the right thing, I think time will tell, but can we fault them for trying to do that? I just wanted to ask Catherine, as our lay person, what have you thought so far? What comes to your mind when you see these kinds of discussions?
What I found really interesting so far, I didn't mention at the beginning, my background is actually social science and psychology. Because I am actually a psychology lecturer. Hi, Sean. I was really nodding and thinking, yes, I can see all the psychological theories here unfolding. So it's really interesting to actually see his point of view as a behavioural psychologist. And I'd also like to ask him to kind of expand on what he would believe would be the psychological impact to society through the division of this vaccinated versus unvaccinated, and the way that there's a narrative to point the blame towards those who do not feel they have informed consent or enough information to make that decision about their own health and their autonomy, free autonomy over their own bodies. But also what's very apparent very early on in the discussion was that this is something that is attacking people who are obese. So if we really need to, it's becoming very evident that we need to be focusing on our health behaviors, as well as, sort of trying to understand and taking all this information. With infection control as well. I mean, there's been a lot on infection control, but I think that really we need to be really looking at our diets.
It's a very, very important point, and one that I guess in the midst of everything we're focused on therapy, but no one has gone to the fundamental or the root cause, which, as Amitav has pointed out quite clearly in his imaging, it goes right straight towards obesity, Amitav. Based on the epidemiology, Amitav, how closely does obesity match in the context of being the primary factor for significant severe COVID-19? Would you say that's the biggest thing? Oh, yeah. Let me just unmute. You're muted at the moment, Amitav.
It is the biggest thing. I think it must be accounting for 60 to 70%, I mean, the susceptibility. Almost, if you are non-obese, you are as much protected as a vaccinated person, or perhaps more. Because this Japan stands out and Brazil stands out as the contrast. And I have seen most of the patients who are, even young patients are obese, who are having severe COVID or who require oxygen or ventilator. So obesity is per se, it reduces the lung function physiologically. Then it is also a marker of other comorbidities like diabetes and hypertension and other things. So it's a quick marker of risk. And you see, particularly in developing countries like India and other countries developing, we don't have very good health services. So I have seen in our own studies, we have done surveys, 50% of young diabetics are not aware of the diabetic status. We just found them in survey. 30, 40, we get a decade earlier. The Asian, due to some genetic problems, we get diabetes and heart disease a decade earlier than the Caucasians. So that can account for a lot of impact in our country.
And Shabira, I think I want to probably bring some balance to this. I think that do we give enough credit for the work that has been done with regards to the research in terms of developing vaccines in a short period of time and actually administering this many to try and stop the pandemic? Is it that what are your thoughts when you look at it from that point of view?
You're asking me?
Shabir.
Okay,
No,
Sabir.
I think do we have a chance? I mean, so we were in the midst of something which is very unknown to us. The whole world panicked. I mean, if you look at the UAE scenario, the pandemic, once we announced it in 11th March 2020, I mean, we never knew what has to be done. I mean, so I think, we had options of diseases which used to come before, and we had variants and variants coming in. So I just wanted to tell you about the UAE scenario. So the first thing that they did was anybody coming into the country has to have a forceful quarantine. And that means, you're put on some gadgetry and then you're being monitored properly. So I think it was painful, it was judicious, but it was done properly. And I think to an extent, I mean, if you look at the ways UAE is, we have 7 emirates, people used to move freely. But from Dubai to Abu Dhabi, there was real restrictions in movement. So one of the good things that they did is UAE signed up with the Chinese vaccine manufacturer, and that's how they were able to give the vaccines to a multitude of people. I mean, if you look at the magnitude of the vaccination program there, it was no difference. I mean, for a national, for an expat, the vaccines were all given. I mean, they've started giving vaccines to children. I think there are pluses and minuses to it, but I think one of the good things, in my perspective, as a neurologist or a doctor on the field, I felt that vaccination and the effective implementation of safeguarding people who have had the infection. And I probably agree with Nat and Dr. Amitabh, obesity obviously is a factor, but due to obesity, if your respiratory system has got an issue, if your immunity has got an issue, if you have comorbidities, I think that's what is the most added value to people succumbing to death.
Mm-hmm.
That's my point.
Absolutely, yes, appreciate it. And not you are also sorry, go ahead, Jennifer. Were you saying something?
Can I just add to what Amitav and Catherine said? So we know that obesity is a factor, and kind of been a joke over this last year and a half during the pandemic that people have gained a lot of weight also, because all the lockdowns and shutdowns did was force people inside and taken away their ability to go to gyms and to go to parks. And here in Hawaii, they shut down beaches and parks, and a lot of people, that's their only effective way of exercise, is to get outside and to walk and to be out in parks and in the ocean. And so all we did effectively by shutting down and not allowing kids to go play sports and be in school was effectively increase their risk by increasing weight gain across the last year and a half. And so I think the greatest failure of public health during this entire pandemic has been a lack of public education. So we need to think about safeguarding all areas of public health, which include spiritual health, mental, emotional, as well as financial wellness. So we really need to take a more holistic approach when we think about a pandemic response.
Well, point made it. And Sean, just before I come to Sean, what I'll ask Sean is I'm going to ask him, with his public health background and behavioral thing, if he had been in charge at the beginning, where would he go? But let's go with Nut. Nut, what did you want to say?
I would like to highlight the importance of obesity, type 2 diabetes, and cardiovascular diseases. We all seem to agree that these are important risk factors. And if we agree, I think we should also agree that we have to do something about it. And I think we can. One strategy would be to promote things like intermittent fasting or intermittent fasting mimetics, because these are strategies where people can actually take control of their own health and reduce the severity of the disease if they should become infected. And I think that is a very important part of what we need or should do. And I think it's an opportunity that is missed.
Very true. And Sean, I'm going to push you here as a public health person. It's easy to criticize the public health response because we're not doing it. But at the beginning of the pandemic, when vaccines were the way out, and people will still argue that vaccines are the way out, what would you be doing if this is how you had to direct the country? Don't you have to use some behavioral techniques to get people to get on board?
Well, look, public health is not something you do to people or for people. Public health is something that you do with people. I would have, and I came up with a concept. I did a presentation in early February 2020, I think, is when the initial paper came out of China that really, in my opinion, still stands the test of time. I think we also have to remember in public health, and I agree with Jennifer, that a public health education has lost its way. But the greatest flaw, in my opinion, has been communication. And here's my communication. And I screamed it back in February 2020. Stop it. I mean, that's what I mean, really, truly. I mean, first and foremost, obesity, cardiovascular disease, diabetes, they're all risk factors for other infectious diseases as well. I mean, we keep pretending like this virus is new, and yes, it is novel, and it is new, and it has some very unique things to it. But we are not. This isn't our first infectious disease. It isn't our first novel strain. We know there are VIPs, vulnerable, immunocompromised people out there. We should have rallied to protect them. We should have rallied to protect the people who couldn't take care of themselves. The young and the healthy, very early on, looked like it wasn't going to affect them at all. We should have kept working. We should have rallied around the VIPs, and we should have taken care of them, period. And by the way, having served on the front line in Liberia with Ebola, we know there are repurposed drugs that work. This is just, like I said, it's horrible to think. It's been some of the darkest days in my 27-year career of public health, where people who know they can save lives and help people, they know it, cannot do their jobs because they're being blocked, or they just simply can't do it. So I would have rallied, Philip. I would have rallied it and protected our VIPs. That's what I would have done.
All right, understood. Now, I'm going to take a point here with regards to coming to you, not with regards to the repurposed drugs, which keeps on coming up. Here's the problem. When we had the situation with hydroxychloroquine early in the pandemic, was it that the scientific community got burnt and they said, we will never do something like that again until we have very clear evidence that something works? Is that a reasonable position that happened? Anybody wants to take that on?
I would like to say that my observation is from talking to people and talking to clinicians, because I had clinicians calling me, oh, my patient has a fever and cough, what do I do? Treat your patient. Like, I do not understand why at any time in history when somebody is sick, normally you try to do whatever you can, whatever is in your power to treat them. Try this, try that, whatever is necessary to save their life. And I do not understand why it became common practice, to send someone home with a thermometer and a pulse ox and tell them if they can't breathe to call 911. The only time people are getting treatment is when they end up in the hospital. It's deplorable. I don't even know another word for it. But, we should be trying anything and everything in our power to save people's lives.
Understood. Not you wanted to say something here.
I think we have to distinguish between prevention and treatment. Treatments should be restricted. The physician should be careful and decide what treatment is the right treatment for a particular patient. Prevention strategies, like I mentioned, intermittent fasting or the intermittent fasting mimetics that we are developing, prevention strategies are something health departments and authorities can advocate, but it has to be made sure that they're as safe as it gets, so that you can advise people to do that even without having looked at them as any physician would do before giving a treatment.
Yep, I understand. And I want to ask Caroline here a question as a frontline physician. And I don't want you to speak as yourself, but I want you to imagine that you are working within the system. And we know how the medical system works. If we have a system and a protocol, it is very difficult to step outside of it. So if there has been no clear directive from the public health or the royal colleges or something, aren't the doctors just right to just continue and do what they normally do and accept that there's nothing that can be done? Is that unreasonable? You're muted again, Caroline, so you have to unmute first. Yes, go ahead.
Yeah, absolutely. I think the real tragedy is on the really the lack of focus on patients and treating sick people, which is where the rubber hits the road. I certainly understand the importance of public health and population health, but it's important to really have a partnership between public health and physicians, which is really about treating individual patients with their individual unique characteristics. And what we've seen is where public health has essentially dominated and prevented physicians from using our knowledge and applying our knowledge to treat individual patients. And the problem is that in the past, physicians are trained to follow public, to adhere to guidelines. And these guidelines are usually rigorously developed over many years. And the difference now is that with this novel disease and virus, there really has been a lack of time to develop high quality research. And there has not been these guidelines. And yet, the importance of empirical experience by physicians based on their understanding of the pathophysiology of the disease and trying different agents have been completely ignored. And so this is the real tragedy, really, is the complete suppression of scientific dialogue and innovation, really, in sharing the experiences, particularly the successes of physicians across the world who have had great success in treating with cheap, available, repurposed drugs while we're waiting for the expensive, well-funded trials to come up with the new agents.
Yes, I understand that, and so before I let Jennifer jump in, I want to quickly ask Shabir a question here, because Shabir, you are in a slightly unique position here because you are both hospital management and leadership as well as clinical. And when we say these issues about being flexible, it doesn't work in the hospital environment. We need a protocol, don't we? How does that work?
No, I think you're absolutely spot on. I mean, one of the best things that the UAE had done was they had come up with field hospitals. I think nobody else would have built so much of field hospitals wherein, they were just looking at the acuity of the cases. And, many of the people were moved, if they're even positive, they were initially moved to quarantine inside the field hospitals, where there are no major interventions that used to happen. The moment that when there is a complication that used to happen, they were moved to the hospitals. So I think, we were so blessed that, we did not have a fearful crowd which used to come in, wherein, people were not segregated based on the equity. So that's one good thing that it had happened in the UAE. I agree to the fact that there is not much of research and development which had happened in this case, but we had people dying and people were not the relatives didn't want to see the body. And, people died, and nobody could do anything for the dead ones. So we were going through some bad times of our life. And I think, that is the price that you pay for a disease which is unknown to you. And we figured out that, we had multiple drugs. I mean, I think the most important thing that had helped us is the most cheapest hydrocortisone that has saved most of our lives. I really want to say that one of the magic drugs that we had done for the treatment of COVID, even now, hydrocortisone is still one of the life-saving drugs that I've seen, in addition to the antiviral and the other life-saving drugs that had been done. So you're right. We went through a lot of learning. I think we could do better. As Sean said, that, it all depends on the psychology of how we are going to face this. I think we have partly won the war. I mean, there are a lot more to learn. And if you look at it, I mean, I'm happy with the way I'm at the moment. I'm in India. I see that there is a lot of movement. People are back to track, back to work, but still the disease is still prevalent. And one thing which I want to talk about is my state, wherein, and I come from a small state in India, where we still do antigen testing, and our numbers are still very high. And I don't know why the government is insistent on doing the antigen test, and publish a data which is not in concurrence with the Indian volume. So it depends and it varies. And as Sean said, we don't have a unified protocol so as to say till today to work on this. I mean, we had world leaders announcing that we want this drug, and on what scientific basis was these drugs asked for? Whereas, we had people getting saved by very proven drugs like hydrocortisone. So, it varies. I mean, and I think, it's about coming up with more clear SOPs to manage this process. Thank you.
Thank you, Shabir. And Jennifer, you'd wanted to say something.
Yes, I just want to clarify something, because I hear this time and time again, and it's kind of a myth that I would like to dispel. I hear people say all the time that this is a virus that we've never seen before. This is novel. We don't know anything about it. And I think that is completely incorrect. This virus was named SARS coronavirus 2 for a reason, because it is similar to SARS coronavirus 1. It is a coronavirus. It has the same genetic structure as SARS coronavirus 1. It uses the same host cell receptor as SARS coronavirus 1. It causes the same disease as SARS coronavirus 1. Scientists have been studying SARS since it emerged in 2002, late 2002 in China. It also, we know a lot about that virus. We've studied it. We've looked at drugs to treat it. There was a time when people were trying to develop vaccines against it. So there's a little over 17 years of research that has been done on SARS coronavirus 1 that could be applied to SARS coronavirus 2. I'd also like to say we have other respiratory viruses, like we see highly pathogenic avian influenza in humans causes the same thing. It causes a highly cytokine storm, highly pneumonia with lung inflammation. And so we can look at how that was treated. And I remember working at that time with highly pathogenic influenza viruses in humans, and they were treating with steroids. So, we can look at other things in the past and apply those principles to what we're seeing with this disease.
Yes, that's very, very true. And but just before you say something, Nut, I wanted to ask Catherine an opinion as a layperson. In truth, does it seem as though it creates more confusion when health experts are not all agreeing? Does that make the public even more worried?
Yes, I do believe that it does. I mean, as Sean was saying, public health is not something you do to people, you do it with them, because you have a health belief model. So people have to internally want to change, and you're challenging beliefs and existing biases there. I think that presenting this as something new, unheard of, that nobody knows anything about, it sets the ground for fear. And my social science and psychology brain is thinking, oh, this is a little bit of Foucault, a little bit of Milgram, and Solomon Asch all rolled into one there. But what it does is it kind of, I think this is my expertise here speaking, is it puts people into a state of paralysis, like a mental paralysis. And oh my goodness, we must do as we're told, because nobody, not even the experts, know what this is. But I think also what that does is that it conditions people into probably making decisions instantaneously, rather than having the time to actually stop, absorb, and kind of work through what is happening to them. I think there's a lot of confusion at the very beginning. There were people fighting in forums online, and some people saying, "Oh, it's just like the flu," and then other people say, "No, it'll kill you. It'll do this. It'll do that." And I think another area of public health that's not been looked at is the mental health toll on the entire population, particularly teenagers. I have a teenage daughter, and the impact to the teenagers and young adults is enormous. So I think that absolutely the approach has been completely wrong from the outset.
All right. Yes, quite true. Quite true. And not you wanted to say something just before, and then I'll get Caroline to make a point.
I just wanted to mention that the way our immune system deals with respiratory virus diseases is the same for all viruses. The immune system does always the same thing. And we had coronaviruses, dozens of them over the last 100 years or so. We just couldn't sequence them, so we didn't know whether it was corona or influenza. So all that idea that we have a totally new type of response by from our immune system to this virus is totally absurd.
Yes, quite true. And Caroline, you were going to make a point?
Yes. I just wanted to say that what's been really missing has been the importance of primary care, and what family doctors have done, and which has been the strength of our Canadian system, is to treat the whole patient over time. And I think public health really should be looking at all the people's health, not just COVID, but also all other diseases and the impact of policies, including unintended consequences. And what we've seen is a rise in suicides, depression, a lot of it as a result of the policies and lockdowns. And, I think this is where, if we're going to come out of the pandemic, we really need to look at the whole person. The holistic approach has been mentioned. The importance of strengthening the doctor-patient relationship and in primary care, because that really is all about improving people's health, better disease management, which has been successful. We know that in reducing hospitalizations and deaths, and yet that has been, not sufficiently recognized.
Yes, quite true, Caroline. Amitav, I wanted to bring you back here because at the end of the day, do you think, based on what you were putting forward, I think Shabir and many people think that we are winning. It seems that cases are going down. Is that a correct perspective from an epidemiological point of view?
We are definitely winning, but not due to human efforts. It is the natures as all pandemics occur, because we did, after the first wave in India that ended in September, October, it came down. We did a sero survey. We had 35% sero positivity in a population of 30 lakhs. But this was more, some of the slums and tenements, congested area, there was almost 80% sero positivity. So they got the and the middle class and affluent people were keeping away, aloof. So they could protect themselves. And the second wave affected everyone equally. So the second sero survey we did in our same area, 30 lakh population, 80% sero positive we got across all social strata. So an all India survey ICMR had done about in the month of June, about 70% of Indians were found to have IgG antibodies. And if that be so, then almost we have reached herd immunity the nature's way, and the vaccination is rolled out now. So whatever is stabilizing or it has come down is due to the natural phenomena of all pandemics. It is not human efforts.
Very, very interesting point. Sean, I wanted to quickly ask you, in terms of where this pandemic has had an impact on one of the areas we don't really tend to talk about from health, which is the financial sector, businesses and so on. Do they need some clarity as to where things are going?
Philip, considering that I think it made international news, we had the worst job reports here in the United States come out yesterday, where even our own president turned around, didn't even take any questions on that regard. Look, we've been hit really hard. I'm a small business. I have a training center. This is a training center here in Atlanta, Georgia. And I think businesses, small businesses, I mean, people have given up everything they've had to go into business. And I think people have lost those things. And I think from a financial aspect and a financial sector, I really don't understand why we are continuing to do what we're doing. It's almost like we're self-imploding because it is tough. And quite honestly, these vaccine mandates, I'm sorry, I think there are some people that are so convicted for a variety of reasons, whether it be choice, whether it be religion, whether it be just to say, I'm not doing what you want me to do. Mandating these things is only going to continue to hurt the financial sector, in my opinion. I think we have to give people control. I think we have to inform people. One of the things, Carolyn, I love what Carolyn said, but our intelligence is compromised. Public health professionals and even physicians cannot educate the people they serve because we get tinkered data. We don't have real data. Show us just straight data and let us look at it. Stop grouping people. Stop telling us this. You're playing with that. The first lesson I learned in School of Public Health when I took my epidemiology course and my stats course, we can tell any story we want to tell with the data. Stop playing with the data. It's compromised. We can't see what's really going on because the data sets we're getting are not clean. They're played with. So in my opinion, again, I think that we need to get people back to work, no doubt. We need to make exceptions for people who are vulnerable. I mean, we do have a real threat out there. People who are vulnerable, we need to make exceptions for them, and we need to encourage them and empower them to do what they need to do to take care of themselves. That's an important psychological component. People have to feel like not only they're in control, but that they're actually contributing to the issue and the problem. And when you take that away, they lose a sense of self-value. They lose a sense of belongingness. And that's not good for anybody in the long run.
Well, I think that what I have to do here is that I need to balance some of the discussion. And I'm sorry, I'm going to have to pick on Shabir for this point here, Shabir. But at the end of the day, if public health and the government think that the best route out of the pandemic is a vaccine, are they not irresponsible if they don't ensure that as many people who can take a vaccine take it? So therefore, if people won't do it voluntarily, do they not have the responsibility to make people do it by some degree of coercion? And Shabir, before you come in, I'd love to hear Shabir's thoughts on this, because I think it is an important challenge from, I think we're thinking about it from COVID, but just imagine that this is measles or another outbreak. You know, we would come back to that, Jennifer. So, what are your thoughts, Shabir?
No, I think I don't want to talk as a physician or a neurologist now. I've lost 4 of my family members to COVID, and 4 of them were not vaccinated. And I've had multiple of my people who had this issue, but I mean, you know, I could only speak. I said I don't want to speak like a doctor. I don't want to speak like a physician. Let me talk like a layman, wherein I want to share my personal experiences. I've had more than 50 people who were badly affected by COVID, and I lost 4 of them. And of the 4, I lost them because they were not vaccinated. So if you ask me, I mean, you know, I live in the UAE, wherein, you know, we have the government giving them a free mandate to do the vaccination. I know people won't agree with me. Even I used to have the same feeling, but I think, you know, I would rather if there are no major side effects, I would still vouch for people to get vaccinated. I mean, it's their choice, but as a physician, I need to express my thing. And with the experience, I've seen multiple people now badly affected. I mean, people whom I have lost besides families. But I still feel that if there is an opportunity, if there is an option to be vaccinated, please get vaccinated. Thank you.
That's well said. Jennifer, you wanted to say something on that point. I'm curious to hear what that is.
Yes. So when we look back at past outbreaks, so you brought up measles and mumps. We had an outbreak of mumps here in Hawaii pre-pandemic. So mumps was rampant. We would try to contain it. We had people who had been vaccinated, both one vaccine and 2 doses, and they were still getting the disease. So what I want to say about vaccination is, as someone who's done vaccine development and testing for many, many years, vaccines have saved many lives, and they've been one of the best things that public health has rolled out in the 20th century and moving forward. That being said, the legal definition of a vaccine is something that is designed and administered to prevent disease. Now, these vaccines that are being used, manufacturers knew from the start, they did not prevent nor disease nor transmission of the virus. So we cannot vaccinate our way out of this with a product that does not prevent the illness. So there's a big difference between other diseases that we have vaccines for. Like, you get smallpox vaccine, one time you're protected for life. So we need to look at going back to the drawing board, studying how the immune response is programmed by natural infection, and basing preventative measures on that programming. These products are not designed to stop this pandemic. We could, by the CDC's own admission, based on the transmission rate of this virus, we could vaccinate 100% of the population and this virus will still continue to spread. So I believe in vaccines. I think they're a great tool, but we need also other tools in our toolkit.
Well done. Well, now I have here with me Professor Shahzad. Now, I'm glad that you've been able to get in. Please tell me you're not having connection problems here. Can you hear me? I tell you what you do, Shahzad. Can you switch off your video? Let's see if we can hear you. Can you try and speak again? Let me hear what that sounds like. No, what you do now is jump out and jump back in, and then we'll bring you back. So just pop out and come back in. So I'll just quickly mention Professor Shahzad is from Pakistan. So he's a public health lead, and they are trying to see if they can bring vaccines into Pakistan. And they're coming across a lot of resistance, and they're having a lot of issues with hesitancy. And it highlights, and this is a reason why I'm trying to see if I can get his perspective, some of the challenges that exist in different parts of the world. Because I think what we have to say is what my position has been is that I think that vaccines are tremendous for high risk people. And based on what we're seeing with regards to Amitav, that could be in some countries up to 70% of the population in the US with regards to obesity. It's clearly different in other parts of the world, but they have had an impact on the mortality for the high risk, at least in the short to medium term. We still can't necessarily get the long term. Hello, Shahzad, can you go now? Are you hearing us? Shahzad? Can you hear us, Shahzad?
Can you hear me now?
I'm hearing you now. Can you hear me?
Yeah, clearly.
Excellent. So listen, I want you to just quickly give us a little bit of background for you. You're in public health in Pakistan. Tell us a little bit about some of the challenges you guys are having with regards to vaccination. Oh, yes, we're still having problems there. We can't quite hear you. I think it probably is the internet connection. We'll see if we can get that a little bit better. But yes, yes, go ahead, Shabir. You wanted to say something here.
No,
Um, you,
Philip, I think I just want to clarify some doubts which are raised by the fellow panelists here. So, we never claim that vaccine is the ultimate cure. I mean, nobody is saying that vaccine is the ultimate cure. But if you ask me, my personal experiences, the 4 people I lost, they're very valuable people for me. I lost 2 uncles and 2 cousin brothers of mine who I have, in fact, asked them to take the vaccine, but they never took it. And that's the reason why I am going into this direction. So, because, I wish that they would have vaccinated. I mean, the chances of them surviving would have been a little more better. That's my not. I mean, I need to apologize, and this is my personal view more than a doctor. This is what I mean. I've lost valuable people in my life, and that's one of the reason why I still insist. If there is a chance to get vaccinated, please be vaccinated, so that you don't lose anything. I mean, if there is no obvious side effects, try to get vaccinated. You will benefit. That's all. Thank you.
yeah, thank you. Thank you for that, Shabir. Just before you say anything, let me see if I've got Shazad. Can you, Shazad? Oh, he's still stuck, I think, at the moment. Can you speak again, Shazad? Maybe switch off your video again. Can you hear me? Oh, I think we're still struggling. Sean, before Sean wanted to make a point. So yes, go ahead, Sean.
I think first and foremost, Dr. Shabir, I'm very, very sorry for your losses and the losses that you've experienced as a result of this disease. And I do want to remind everyone, this is evidence that we do have to stay vigilant in how we deal with what we're dealing with. The one thing that and I love what Jennifer had said, and Dr. Shabir, I love what you've said as well. The one thing that I really want to encourage people to do is to actually have a choice and do what they feel they need to. I think it's a bit premature to, I'm not sure whether you're trading one poison for another. If you do get a vaccine, what do we see later on? I have no clue. I think people have to have data. They need to be able to assess their own personal risk, and then they need to be able to make their own personal choices. And that vaccine is not the only thing we use to fight this disease. We look at early treatment. We look at repurposed drugs. We look at other strategies in addition to the vaccine. I think that's critical. But my last point, I think this is, a very, very important component when we talk about this vaccine. People have to have the ability to choose. The only benefit of this vaccine is not physiological. It's not scientific. It's not health. It's not physical health. If people feel like a vaccine is what they need to get back to their normal life, to feel safe, to feel secure, to get that psychological hug, then get the vaccine. If that's what people need to get back to normal. But the reality is, I still think it is far too premature to say that this vaccine is something you should recommend for everyone of all risk groups, because we just don't know what long-term side effects are. And quite honestly, it's like you're trading one cancer for another. We don't know. You could get the vaccine and for the short-term benefit from it, but we don't know long-term. And I think that's something we still have to consider. The science is still out.
Yeah, I understand. Let me
Can
see
you
one
listen
more
to
time.
me now, Flip?
I'm hearing you now, Shazad.
Okay.
Yes,
I
go
just
ahead.
wanted to add what the discussion is going on now.
Oh, we keep on losing you. Oh dear. Yes, we're having signal problems there with that, Shazad. So that's a bit of a pity. But I'll share with you some of what Shazad had said before, is that he was pointing out a very interesting statistic in Pakistan. And he highlighted that I think 31% of their deaths were younger people, and of which the majority were male. Now, I hadn't come across that data before, and I was saying that data is extremely important, because if that's the case, it changes the way that we could think about how the disease is impacting. Is this just a Delta variant thing, or is it because of COVID? What thoughts, Jennifer?
Yes, we know that males are more susceptible, and I think this has to do with the differential expression of the receptor, which is ACE2. So we know that there's different levels of expression based on gender, age, and also comorbidities. So, and I wanted to I had some information on ACE2. So we know that it maps to the X chromosome. We know that it's expressed throughout the body. And we know that young people and those who are less susceptible have a different level of expression of this receptor. So I think that can explain partially why we're seeing this difference in susceptibility.
Okay, great. And we're going to try one more time to see if we've got Shazad. You want to try and speak again, Shazad?
Yeah, can you listen to me now?
I'm hearing you. Let's hope it stays.
So I was referring to the vaccination status in Islamabad. We achieved around 65% vaccination coverage in Islamabad. There were more than 360 patients admitted.
Oh man, I'm getting so upset with Pakistan and the internet now. Yes, I think we've lost that again. I tell you, it's a pity because that information I thought was really, really valuable to hear. Not any thoughts about what you've been hearing?
Yes. As an epidemiologist, I look at the population and not at the particular patient in front of me. And that's a very different approach from what a physician does. So one of the effects of vaccination is that the immune system acts earlier, not after a 5-day incubation period, but after a couple of hours or maybe a day. So that means we are producing fewer virus. If somebody gets infected, and even those who are vaccinated can get infected, the person produces less virus, has a less severe disease, won't die, but also does not spread because there's not enough virus produced to give it to others. So vaccines also reduce the transmission, even though they do not reduce the infection. And I think that is a major problem, that language is often not used at that precision to actually reflect what's going on.
Okay, great.
And there's one, so from an epidemiologist's perspective, the value of vaccination is that we are shortening the time to herd immunity. And herd immunity is what ends the disease. And that's the opposite of what we are doing with mitigation or lockdowns. Mitigation or lockdowns are flattening the curve, so it takes longer until we have herd immunity. So the vaccination and lockdowns have the opposite effect. And if we do both at the same time, it makes as much sense as sitting in a car and hitting the brake and the gas at the same time.
Yes, fascinating. So listen, we're about at the end as to what we're talking about, and I want us to think about where we should be going. What would be our recommendations if we were in a position to add anything? Let me try one more time before we do that with Shazad. Go ahead again,
Philip,
Shazad.
can you take my WhatsApp call?
Well, not on WhatsApp. You have to be.
Hello?
But we're hearing you. Go ahead.
Hello.
Yes, and we're hearing you at the moment.
WhatsApp call?
Not WhatsApp, but we're hearing you, so you can speak. Oh, I don't think he is. I don't think he is hearing me. Oh dear. All right. So let's just do a quick wrap up. I'll start with you, Amitav, then, just to see where we are, where we're likely to go. You have to unmute yourself first, Amitav.
Like countries like India, where we are reaching 80% of natural infection, we can avoid duplicating the nature's efforts. we should not vaccinate people who have already recovered from natural infection and go for the rest 20%, particularly the vulnerable, focused prevention. So we will reach herd immunity faster. What is happening is such a large population, 90 crores have already got natural infection as per the latest antibody survey. And we are again immunizing with 2 doses, each one of them, the waste of resources. And we are wasting time. So we could expedite the process if we recognize natural infection, which the scientific community somehow is not recognizing natural infection as a immunity. So that is the thing.
I've got Shazad on WhatsApp with me, and I'm going to try and see if he can speak through WhatsApp to my microphone. So let's hear if that works. Go ahead, Shazad.
Yeah, hello everybody. Can you listen to me now?
Yeah. Mm-hmm.
Okay, thank you. So I was just telling you that Pakistan, had a very unique type of this pandemic over here. We had 4 waves starting from the last year, 26th February. We started vaccination in this year, February. The vaccination coverage is currently around 20%. But Islamabad being the capital city and a smaller city, we have got around 65% population vaccinated. But if we see the data of hospitalization, you will find it very surprising that around 95 to 96% of the people who are admitted in the hospital, today the number was 362 in various hospitals, only 96 to 97% of them were non-vaccinated, and only 3 to 4% are vaccinated. This is a very, very huge difference between these two. Another issue is that we are doing vaccination with identity card, the national identity card. We call it a computerized NIC, the national ID card. So whenever there is a death or an admission into a hospital, it is very easy to analyze, to link it with the vaccination status, because vaccination status is also being monitored through this national ID card. So what we have done is we cross-tab all these things, and so far what we have seen in Pakistan, that vaccination has had a huge impact on the mortality as well as morbidity in the country. One thing more, Pakistan is the only country which has the highest number of vaccines available. So we have 8 different types of vaccines available. So from Sputnik to CanSino to Sinopharm to Sinovac, Pfizer, Moderna, all of these are available. I think we don't have just Johnson and Johnson, and there is a locally assembled, the locally partially manufactured Parkvac also made by the Chinese in Pakistan. So all of them have effect, but to us, the best one which we have got is the best results are from Sinopharm, and the second one is then Pfizer. So and then Moderna. This is something which we have been analyzing now. I'm a member of the highest level committee. We call it NCOC, the National Central Coordination and Organizing Committee of for Pandemic. So what we have seen is we have seen a huge impact of vaccination, and we have almost eliminated the 4th wave. Today there were around 932 cases reported out of say 45,000 tests done. So the positivity ratio is going around 2% per day. Deaths are around 20-21 per day, and hospitalization are also going down. So for me, vaccination actually made some impact, but like I heard the talk by Witkowski and Kaufman and Jennifer, there is an element that there are many infections going on in the community. We don't know that whether this immunity in other parts of the country is due to that active, the active immunity got through the getting an infection which is asymptomatic, or it's an effect of and sort of the vaccination as well. So 2 doses of vaccination plus some people have got 3 doses as well because of traveling, internationally. They wanted Pfizer and Moderna. So initially they were given Sinopharm and then they got a booster for travel purposes. We haven't seen much of side effects so far. It's too early to say. But recently one student died in Punjab area after 2 days of getting vaccination. And but the investigation said that there may be some other reasons, congenital heart disease or something else. It got Pfizer actually. The death was due to Pfizer. No death reported from Sinopharm, no death reported from Sinovac, none from CanSino. There were few cases of Bell's palsy. There were few cases of syncope, a sort of palpitations, fibrillation, atrial fibrillation, admissions, but not much. So we had been feeding all the data into Uppsala, the Uppsala, the whole data set of AEFI. We had been doing this kind of thing. I think Nut Witkowski is asking. I am the Vice Chancellor of Federal Health Services Academy in Islamabad. I'm a professor of public health, PhD, and medical doctor. I teach health economics, health financing, and health system management. And I'm a member of the decision-making body at the federal level in Islamabad.
Wonderful.
Over to you, Philip.
Yes, thank you very much. Excellent. Thank you. Shabir, you wanted to say something. Go
I
ahead.
think the question is to Shehzad. So the seropositivity, is it by doing an antigen or it is a RT-PCR?
We have done RT-PCR.
Yeah. Yeah, so they did RT-PCR. I think I have to mute him temporarily here. So yes, wonderful. So well, since I've got you here, Shabir, what are your thoughts on where we should go? What is the way forward?
No, I think we are winning this. I think we're winning this. I don't know about the difference of opinion of people, but I'm a person on the field. I mean, I've been a doctor. I've lost people. I'm still looking after people who have got affected by COVID. I think my personal opinion, with the knowledge that I have, the limited knowledge that I have, I would like to say that even though this might not cure COVID, this is still the best thing to do. Try to get vaccinated. As the fellow panelists, a few of them, they were saying that we need to really look after the public health interfaces of all that, obesity and all that. That's without COVID, and with COVID that has to happen. And at some point of time, when you are really sick, statistics doesn't matter. It's about curing patients. And when you are there with the patient, you need to behave like a doctor, and statistics won't help you there. That's my thing to it. And thank you so much, Philip. It's a great, amazing panel of people. Jennifer, Catherine, Carolyn, Nat, Amitabh sir, and Sean. It's a pleasure to meet you all. And I would like to learn and listen to you guys more. Thank you so much.
Wonderful, Shabir. And Jennifer, your thoughts?
Yeah, so I would actually like to echo something Dr. Robert Malone said, are the 4 key points moving forward. And I'm really glad that we're talking about this. What is the way forward? So first is reserving vaccine for those who are at high risk. So we know who are the high risk populations. We know it's the obese and the elderly. And we also need to make these vaccines available worldwide. So we have this disparity. And one of the problems, I think, that during this entire pandemic from the start is this public health disparities. And we've been focused on, lockdown, shutdowns. All of this has been focused on what's been called the Zoom population. So what we've done is we've disenfranchised whole populations of people. We've made poorer, and we've put people out of work who have no other way to support themselves. So we really need to make these vaccines available worldwide. I think boosters need to be held off until we can get more high-risk people in the world the vaccine if they want it. The second thing is to make early interventions widely available. So treatment from onset of disease in whatever fashion that is. Last year, I saw people getting azithromycin and dexamethasone. They were doing great. Give them an inhaler, something to prevent them from being into the hospital. We know that there are drugs and early treatments that can affect the health of the people, and they won't have to go to the hospital. The third thing is testing. We need more rapid testing available. Here in Hawaii, they're piloting at home point of care tests. So you can take a test at home, and then you will know before you go out what is your status. So we need to make that more widely available to the general population. And I think the fourth and most important point is we need to address the fear of this disease. We know that not every person has the same risk to disease. We know that a lot of people are at no meaningful risk, like children and young people. So we really need to address the fear. And again, communication and education is really key there.
Thank you. I'm going to grab Catherine because I know Catherine has to go just now. So what are your thoughts, Catherine, as our lay member?
Yes, I'm a lay member with a little bit of information regarding social science and psychology there. But I think that just feedback on the ground with the general population, I think education is key. I think that obviously the virus, it's been presented as very fearful, but that's in order to gain control, gain people's attention. As the health belief model, if a threat seems further away, they'll do less about it. It's like with smoking and lung cancer. You know, that threat cognitively is over there. So there's a kind of a cognitive dissonance there. So I think by educating and empowering people that this is what you can do, this is how your immune system works, this is what this virus is, and this is how you should be eating and exercising and taking care of your physical health, but also your mental health as well. The stress will deplete your immune system faster than a McDonald's burger. I think that there really needs to be, we need to be focusing on mental health and what we can do to lift people. Also, Jennifer's mentioned the socioeconomic impact on people. How can you expect people to be healthy if they're economically on their knees? You know, people are becoming homeless, their children starving. And mental health is falling to pieces. So I think that you need to, rather than beast people into taking a vaccination, is to give them power over their own health and their own body and the autonomy back. I think also just my observations of how information is being withheld, that actually I think that if it was anything else, I think people would have been privy to. And so why are we holding back some of the things that have gone wrong? Why are we holding this back from the public? Why are certain things, why are world-leading epidemiologists being kicked off LinkedIn, for example, just because they've said, oh, hang on a minute, there's something we need to be looking at. As we move forward, I think humanity needs to be unified. All the experts, they all need to come together to scientific discussion. We all need to get, if all the experts and the pharmaceutical companies were, hey, look, we're all in this together, and this is what we're trying to do. This is where things we think we might need to look at this again. Obviously, we know that this is, that their answer was to bring out a vaccine, but there's so many different vaccines, and I think that when we give power to people, power comes through education and knowledge. I mean, yes, there will be some people who will completely just ignore it. But I think that we kind of really underestimate the layperson and treat them as if they're stupid and keep them on a need-to-know basis. And this is what you must do. Go and have the vaccine. You must do this. But where's the informed consent in that? There isn't any.
Yeah, thank you very much, Catherine. Thank you very much. And Caroline, I wanted to get your takeaway thoughts.
Absolutely. I can't say, how much the important perspective that Catherine brings from the patient's perspective. One thing I think is really to end the pandemic, we need to take an approach that is not a single, one size fits all, but to consider a multi-pronged approach, which considers the risks and benefits, the preferences and social situations of the patients. I'm very concerned about the damage to the public.
Oh, I think we've lost the connection there with Caroline just there, but I'll bring in Sean and let you get your final thoughts, Sean.
Well, being that we're dealing with UK, you're hosting this, I'm going to give you a cup of tea, so to speak. So I'm giving you an acronym, TEA. Okay, this is where we are, and I want to acknowledge Dr. Tala Ahmed and Glenroy Haywood with the T. The T is truth. And Dr. Tala says, unarguably, vaccination has had positive effects. We can't argue that. I agree 100% with you. The question is within what population? And Glenroy says, Sean, have you, many have died waiting for outcome data. We know long-term outcome of death in unvaccinated is 99%. Here's the problem. Majority of people who are dying are people of age and who have some type of pre-existing condition like obesity. So when you're recommending vaccinations and you don't know long-term side effects, you recommend and protect the most vulnerable people, the VIPs. That's who gets vaccines. That's who should. Look, we need truth. That's the T. We need truth about the vaccine. We need truth about who's dying. We need the truth about who's getting sick. We need the truth all the way around. Not hindered, not blocked, truth. That's what we need first. The second thing that we need to do going forward, Philip, in my opinion, is we need to empower people. We need to empower people to test themselves. This is simple. Antigen test. We need to give this to people so that they can test themselves. And if they are sick, this would be the only time to wear a mask. When you're sick, you wear a mask. When you're healthy, throw it out. In my opinion, that's again my opinion. We need to, in essence, make sure that people have the ability to behave and get early treatment. They have to have access to early. This is really the only place. I like what Jennifer said. I went in one day. I was sicker than a dog with COVID. I still wanted to get tested. I got tested. Do you know, again, the clinician said, when you can't breathe, come to the hospital. I was sick. There was nothing else done other than you have a positive test. Well, thank you very much. All right. And here's the last letter for T. A. I want accountability moving forward. I want people who have lied to be brought forward and questioned and talked to. I want people who are making profit off of this, profit off of the suffering and the loss of people, to be called forward and talked to. And last but not least, because I lived through the days of HIV, I saw people who were stigmatized, people who died alone as a result of the infection because politics got involved in this. I want politicians out of public health. I want them completely out. I want them gone forever. And that's why, Philip, I love this. This is important for me to say to you. I want you to keep doing what you're doing because I want people to tell their stories. I want all the losses, the deaths. I want this disease to have a face. Because when we saw Ryan White, who had HIV, when we saw Magic Johnson, when we saw Princess Diana going, when the disease got a face, the politicians ran because they could no longer win. It wasn't about politics anymore. It was about the loss and the suffering of the people. So I think moving forward, I want T, I want truth, I want empowerment, and I want accountability. Philip, thank you for having me here today. I appreciate you.
Wonderful. Excellent. Not your thoughts?
Mute myself. Okay. I'm unmuted now. Where are we? We are at the point where we have to expect that the next wave will be of a virus that evolved to escape the vaccines that we have right now. The Delta is already, and others that are circulating right now are already partly resistant, and we will see more resistance. So at least the viruses that we have right now will be less effective. We need to improve. What else? We need to improve not the mitigation. Lockdowns are causing death because they take away the advantage the vulnerable would have from self-isolating while the virus is spreading everywhere else. If everybody does the same thing, the virus also does the same thing across the whole population. More of the elderly and vulnerable get infected, and we have many more deaths. So, and mitigation flattens the curve, which gives the virus enough time to create new versions that are resistant. So what else should we do? We should improve population health. And I mentioned one way, and there are lots of other ways. We should make sure that people, if they get infected, have a smaller risk of having a severe disease and dying. It's about the same thing we are expecting from a vaccine, but the vaccines are too specific to guarantee that this is going to work in the long run. Mm-hmm. So we should use things like intermittent fasting mimetics, like those that we are developing. But there are many other things we could do. We should make sure that people don't die and don't have a severe disease, and then we can live with it and let nature do what nature has done for a couple of million years successfully, because otherwise we wouldn't be sitting here.
Thank you very much, Nat. And we've got Caroline again. Hopefully your internet connection is a bit better.
Yes.
Yes.
I'm moving around. Thanks very much. I just want to reinforce what everybody has said. The importance of looking at the whole big picture, using a multi-pronged approach. Really, because we're talking about epidemiology and public health, we cannot ignore the importance of looking at the social determinants of health and what we can do to really shift the risk factors such as obesity and the mental health, the root causes that are causing the mental and physical health problems, rather than a singular focus on case counts and COVID numbers. And I would implore the leadership and the governments not to suppress physicians and block our ability to treat our patients, because that not only is something that prevents us from upholding our Hippocratic oath. I'm very concerned on the long-term effects of causing public losing their trust in science and medicine, because we have to deal with the long-term consequences of this COVID pandemic for a long time, including the future medium and long-term chronic diseases.
Wonderful. Thank you very, very much. I don't know if Shabir, I'm just going to quickly see if Shazad, sorry, is working on this. Probably not. I'll just get him to say something on my system. So, Professor Shazad, I'll just let you say a word to end.
Yeah, I can hear you.
Yes, go ahead. You can speak now.
Okay, so I think I'll echo with everybody that although we as scientists, we should be looking for more data, more evidence on what the vaccines have actually, how do they work, what kind of complications they can do. But so far, whatever data we have in Pakistan and in many of our similar countries, it has worked to a huge extent, not in preventing the disease, but in prevention of complications and a lot of mortality reduction. So this is something which is visible in our hospitals. Whenever we do the analysis, there is a huge difference between vaccinated and non-vaccinated complications and all other things. So we should follow it through. We should study the people who have got vaccination, and we can follow them as a cohort, and also look at the other people's other community members who have not been vaccinated and how they are moving ahead. So these two-prong approach, I'll call it, will give us more information. Given that every subsequent wave in Pakistan has been a little milder than the previous one. We have got 4 waves. The 4th one was a little too, messy, because we had Eid, we had Muharram, we had a lot of religious gatherings. So there was an issue, but now I hope we can increase the vaccination coverage to up to at least maybe 50% of the target population by the end of December, which we have targeted, and then it will be better. We will be in a better position to go for further. We call it a smart lockdown and area lockdown, where the cases are more intermittent lockdown. So this is something we are already doing on. So I hope we can manage this, hopefully.
Wonderful. Thank you very, very much. Appreciate everyone for being here. This has truly been a fascinating and tremendous discussion. Appreciate all the input from everyone here. I'm sure that we can have, well, my hope would be that we never need to speak about this kind of thing in the future. But I think that realistically, the hope is that we will be able to find solutions now for the future. Thank you all very much. I appreciate it. And thank you to the audience, and a wonderful evening and morning wherever you are.
Thank you, Philip. Thank you, everyone.
Everyone, bye everyone, bye.